I have the honor of introducing our next speaker. This is Dr. Binesh Patel. He's an emergency medicine physician by training, but he currently serves as the CEO of McLaren Healthcare. In this role, he develops, implements, and directs the overall strategy for the organization, which employs more than 640 physicians and surgeons across 40+ specialties in 150 outpatient centers throughout Michigan. Now, prior to this role, Dr. Patel serves as the Associate Chief Medical Officer and Senior Medical Director at Blue Cross Blue Shield of Michigan, and also the CMO at McLaren Flint. And I can tell you, and I'm embarrassed he had to tell me about this today, but he also served as a resident of the General Surgical Service at Detroit Receiving Hospital back in 2000 on the Gold Surgery Service, where I was the attending. And one day, our second-year resident wasn't there, and he had to be the pit boss in the ER. And he was all excited about it. But then about 7 p.m. came around and he was like, I need some help in here, please, somebody. But anyways, please welcome, I think Dr. Binesh Patel has a really unique perspective, being an ER physician. He was an administrator at the Blue Cross Blue Shield and now with a major health organization, top administrator. So I look forward to hearing what he has to say today about some of the challenges in healthcare that we're facing and, especially with our current political environment. So please give a warm welcome for Dr. Binesh Patel.
I have to make one correction. I serve as the CEO of the McLaren Medical Group, but not as the McLaren healthcare system. There are McLaren folks here, and I don't need that getting back to Phil Incarnati. So please, I think we said at the beginning there's no recording, so but Dr. Carlin gave a sort of a brief overview of my journey. And I was thinking I would come up here and introduce myself and tell you what I've actually accomplished in about the last 25 years. I'm going to do it a little bit differently. He took away some of my thunder. So I trained as an ER physician back in the early 2000s down in Detroit. Had the pleasure of being on Dr. Carlin's Gold Surgery Service in Detroit, for those of you guys that recall those services. Moved on to practice emergency medicine, get into administration, and during my time as chief medical officer, and there's a point to this, the way I'm describing this, because I feel like for me to be able to stand up here in front of you, I had to go through this journey where I got to work with one bariatric surgeon. And then during my time as a chief medical officer, I got to be yelled at by another bariatric surgeon in Flint. So we had that. And then when I went to Blue Cross for a short while, I actually served as the Blue Cross administrator to help with medic. So, and then I come to back to McLaren and I get a call from Amanda. I don't know where she is, but I get a call from her over a year ago to ask if I could come and speak to this crowd. So that's the journey. So if you ever want to stand up here in front of a crowd like this, first of all, you got to start with being a resident under Dr. Carlin and be the pit boss. So when I've thought about what I wanted to come up here and talk about, so a few months back, I actually met with Amanda and just sort of thought about the different topics that I could present up here. And I scrapped all of that because in the last few weeks, just a lot of things that have been going on in healthcare, and especially at Washington. And I thought I would highlight some of that because we might look at that and maybe joke about it. But there's some real impact that could happen. And I thought I'd take the time to be able to present that. So just again, a quick overview of the actual medical group within McLaren. We started off managing basically ambulatory services, so primary care, and a few specialties and located across Michigan. And that's over time has evolved into employing over 700 healthcare providers, and the number is going to continue to go up. Not so much that we're actually hiring more positions, but maybe absorbing services that are already in existence within our health system. And because we have recognized the need for a more reliable model, and this was one of the things I wanted to talk about, but I think we've many of us in the room here have probably gone through the outside forces that have come into healthcare and the disruption that's caused. And so I thought probably you guys have been bored to death about the conversations around that. But the result of that is that McLaren Healthcare, not unlike many health systems that are represented here, has looked for a more reliable model to secure services that are functioning within hospitals. So emergency medicine, radiology, pathology. One other unique thing with McLaren is that we also have 30 rural health centers. So I do feel that as a health system within Michigan, we really do touch upon all aspects of healthcare within the state. In 1996, so the aforementioned, the actual CEO of the McLaren Health System, Phil Incarnati, and the team back in 1996 actually came up with this mission statement. McLaren Healthcare will be the best value in healthcare as defined by quality outcomes as cost. And I think we all have adopted that across health systems, not just in Michigan, but around the country. We really do talk about value. So what is the direction that healthcare is taking? Put up the signpost. I mean, we could put lots of signs on this, but the three areas that I really want to talk about is as reimbursement is decreasing, efficiency has to increase. And then I also want to touch upon security, because I think that that's an aspect that we don't always think about in healthcare, but healthcare is such a vulnerable sector when it comes to security. We all know that reimbursement is reducing. So how do we combat that to ensure that we can continue to provide the services across the state and to the communities that we serve? And when we look at specifically reimbursement, what we're thinking about is a reduction in Medicare and Medicaid and educational programs and research. And we have seen that already taking shape this year. For instance, in research, new mandates that have come out in terms of what programs that we healthcare can initiate, and if we don't meet those mandates, potentially lose funding or just a decrease in total funding. And understand, if you look at, especially in the oncology world, when you look at research, it's those studies that sometimes are the only healthcare that those patients are receiving, the patients that are part of those studies. Education programs, some restrictions that have been proposed, such as what percentage of our trainees are US graduates. That's been proposed. There's many other things that have been proposed to try to ensure that there's a tighter control over education. And if you don't meet these mandates, again, decrease in funding. ER, for those of us that are here representing ER, we're well aware that there's a push to have a mandatory 4th year of service, but that comes with no additional funding in training. So how are health systems going to manage that to add a 4th year? And then there's other aspects that have been added to those training programs that have to be really thought through in terms of how to deliver that training, or potentially be subject to a loss of program or a loss of funding. So in terms of reimbursement, some of the key provisions when it comes to the Medicare and Medicaid. The one big beautiful bill act that recently passed in the House and is now sitting in the Senate. And again, I made comments earlier about, we may joke about these kinds of things, but what is it actually, what's the impact? What could this do? And if this bill doesn't pass, don't worry, something else will get proposed that'll have similar effects. So when we look at the Medicaid aspect of this, we all know about the work requirements, requiring at least 80 hours a month to qualify for Medicaid. There's coverage restrictions. So, for instance, gender affirming, Planned Parenthood, these are things that are being restricted. And this is all going to lead to an increased state responsibility. So greater share of the administrative costs, that burden will fall on the states. Higher penalties for distribution errors. So what does that mean? If these aspects of these provisions are not adjusted, this is going to result in a significant decrease in funding on the Medicaid side. Medicare adjustments, funding cuts, a 4% reduction in funding, eligibility changes. So explicitly limiting, for instance, to US citizens. All of these things are going to affect or could potentially penalize states and decrease Medicare funding. The Supplemental Nutrition Assistance Program, the SNAP changes. So the benefit reductions that are being proposed could result in almost $285 billion over the next decade of reduction. And again, the work requirement expansion. So I put this up here because, and especially with our ER colleagues, we understand the impact of this. If there's a decrease in funding within our communities in terms of the healthcare that they could receive, and especially Medicaid population, that community, where are they going to go to seek healthcare? So the proposal for the restrictions and use of provider taxes is also going to further decrease potential funding for Medicaid. So the moratorium on new or expanded provider taxes will limit what the states can do to be able to pool or fund that Medicaid portion for the state. Limits on state-directed payments. So this will block any new or expanded services that would exceed Medicare payment levels, or in some cases 110% of that. So essentially put a cap to what can be funded, and then closing loopholes. So again, all of these things, when you take this into account, we're going to see a reduction in funding from Medicare and Medicaid, and you have to think about what is that impact in the communities, and where are those patients that do receive that funding for their healthcare services? Where are they going to go to get their healthcare? So, and then what's the impact in Michigan itself? Budget shortfalls. So funding gaps that the state could address through all of these different programs are now going to be restricted. And so it's going to result in a budget shortfall. Not only will it result in a budget shortfall within the state, and what the state can do to fund that, but remember this, whatever the state puts up there, it gets matched by the feds. And so now if the state can't pool enough money, it's not going to get enough matching funds. So it's almost a double hit. And then what's that impact on the actual healthcare providers? You're going to see the biggest burden fall on underserved and rural areas. I mean, we know that. So again, those of us that serve in communities that are considered underserved and rural, we're the ones that are going to take the brunt of this. So broader implications. The overall potential impact on Michigan, as I mentioned, Medicaid coverage loss could be up to 30% of our Medicaid population. So almost 750,000 people in the state of Michigan. The financial strain on healthcare providers, so just hospitals alone are looking to lose about $2.3 billion. And by the way, this isn't just going to affect hospitals, it's also going to affect nursing homes. So again, the effect of this gets cumulative as we start to look at all aspects of healthcare. Within nursing homes, we're looking at about a $325 million reimbursement decrease. So think about that. Think about all of our nursing homes and how strained they are today, and now get impacted by a loss of funding. And where, again, what does that impact on the nursing home, and how does that translate to the rest of the services that are provided? If the nursing homes can't provide that care, again, where does it fall? And then think about the economic and employment concerns. So again, within healthcare, if funding goes down, we can't pay staff. So remember that there's a large healthcare, most of healthcare, most of the people that work within healthcare, they don't work jobs that are necessarily unique. Those of us in the room might, but think about within our hospitals or clinics, et cetera, those individuals that work in those areas could go work in other sectors. So if healthcare can't deliver a good compensation to those people, they're going to go seek jobs elsewhere. So what do we have to do to combat that? If reimbursement is going to go down, how do we try to combat that? And the work that you do here, not just in these CQIs, but all the rest of the CQIs that exist today. We talk about value, we talk about efficiency. All of that is going to result in not just improved or better care for the communities we serve, the people that we take care of, but it will result in a more efficient use of the dollars that we spend in healthcare. And that's really what the goal here is really to achieve that value. So I gave you all this doom and gloom. It's not my intention. It's really just to paint the picture of what is going on in healthcare today and in terms of reimbursement, and how, and the work that you do, how is that going to be impactful? Within health systems, we're looking at expenditures. We're looking at all avenues of expenses and how we can reduce our expense load so that we can continue to deliver the care that we do. One of the areas that within McLaren, and we're not new to this. I shouldn't say, I'm sorry, this is not a new concept. We may be new to this. McLaren was essentially a health system by acquisition over really just the last 25 years or so. Some of the health systems that you represent are further along in this journey, much more mature in how you function. But one of the things that we do and what you do is system-wide services. So whether it's a service line approach that's coordinated at a centralized location, it's important to think about what efficiencies you can manage by doing that. Within McLaren, we have a stroke network, a cancer services that are pretty mature, and we're starting to embark on cardiology. As I said, some of your health systems are much further along in this. This is all good work that's being done within the health systems to ensure that that efficiency is there, and how do we promote some standardization to continue to improve the care that's delivered. Finally, I thought it would be important to talk about security and specifically around cybersecurity. Because this is the one area that I think healthcare does not do well on. And I can speak on my health system. We had a major cybersecurity event late last year. Other health systems that are represented here, we've all gone through similar cybersecurity events. And this is the area that I think really does need to get more attention and more action around because of the incredible impact. For us at McLaren, basically took us out for a month, and the inability to be able to see the complete patient charts or be able to deliver that complete care had a significant impact on the communities that we served, and the patients that we served. And other health systems have felt the same way. And it's not getting better. We thought it was. This is just April of this year, the data breach report. And you can see we had a significant drop in February, thinking that, okay, there's an improvement there. But we have seen it start to increase again in April. And just the three big healthcare data breaches that we saw in April, look at the impact of individuals. When you look at, if you start at the bottom, Ascension Health, almost 450,000 individuals affected. You go to the Blue Shield of California. By the way, this isn't just health systems, right? This is payers as well. But look at the impact, 4.7 million. And then at Yale, 5.5 million people affected. And this is cumulative, right? So these are not, look at these three areas, they're not necessarily overlapping. So this is just in the month of April, just the three biggest in the month of April. We saw there was over 60 data breaches. This will continue after coming out of our incident last August. I remember sitting in a meeting and our cybersecurity team basically telling us it's not that we're not trying to prevent the next one that comes along, or I shouldn't say that, but it's not a if, it's a when. It'll happen again. And so what are we doing as a health system? What are your health systems doing to arm yourselves with the tools so that if it does happen, or when it does happen, that you can get back to normal services as quickly as possible. And for those of you that have not gone through a cybersecurity event, please understand that the impact that this has on the providers, on the clinicians that are in your hospital, not just the physicians and APPs, but the nurses, everyone that takes care of a patient. Not if the cybersecurity event is powerful enough to knock out how you can take care of patients, you could be blind to what you're doing. And as a clinician, to not be able to access or be able to see that data is so powerful. And so one thing I do ask is that you go back to your health systems and just understand what is it that is being done to combat this at your locations. The time I have. So the last thing I was asked to sort of talk about was a journey of the emergency department, and I've had the unique opportunity to spend time as a clinician, administrative role within the hospital, some time with a payer, and now running a large medical group. And so I have some the ability to be able to see some of the aspects of healthcare that's been delivered across multiple parts of healthcare and see that vision of what it looks like. And what I would tell you is that the overall goal is the same. The overall goal is to deliver the best care that we can, not just at a population level, but also down at the individual patient level. And there's probably no better way to examine how healthcare is delivered than through the eyes of the patient in the emergency department. And so when you look at what does the emergency department physician or APP think about, and it's pretty straightforward. You're looking at the patient right in front of you. You want to stabilize that patient, provide that medical screening exam, and then start to think about that care coordination. If you're the patient, I'm sorry, if you're the hospital, you're thinking about how you're going to move that patient through their journey of healthcare, through that, whether it's within the four walls of the hospital or in whatever additional services that you're going to provide. And so access to nursing, the essential services, lab, radiology, transportation, housekeeping, all of that has to be weighed in. And then the admission and bedding flow through that hospital to final discharge. The insurance, the payer, what are we looking at on that side of things? It's the appropriate level of care. Are we delivering to the patient the right care at the right time with the right resources so that we can provide the best value and reduce cost? And again, we all look at each other differently, but at the end of the day, it's all about the patient and it's all about how we can deliver that care. And so the work that you do, whether it's MBSC, Medic, or all of the other CQIs, it's always looking at providing efficiencies, providing value. And everything that you can do within your scope has an incredible impact on how healthcare is delivered, and specifically how it's delivered to the individual patient. So that is the extent of my conversation. I hope I gave you a sort of an understanding of where we sit today, some of the bills that are being passed or potentially being passed, and what that impact could be on healthcare, and then what can you do in your CQIs to help to mitigate that impact to the actual patient. Thank you.